The saying is, when life gives you lemons, you make lemonade. My oldest son, who is going to be 13 next week, he was diagnosed with metastatic Ewing sarcoma. As his father and a cardiologist, I started looking into the side effects of these medications. And as I worked through that process, trying to make sure when he is all done with this, what do I need to focus on as a physician father to put him in the best shape to not only survive his treatment and his cancer, but to live a healthy life. That's when I started to uncover the idea of cardio-oncology. Not only do I have a personal invested interest in this, but as a professional, there is no reason why the patients that we serve locally and beyond cannot benefit from what I have had to deal with as a parent and a cardiologist with a son who has had exposure to multiple chemotherapeutic agents and radiation that put him at significantly increased risk in the future for cardiovascular disease.
In most of our episodes, we're talking with guests who are cancer survivors or cancer doctors. Today, you're going to meet a cardiologist with USA Health, Dr. Christopher Malozzi. Dr. Malozzi has a special interest in the connection between some cancer treatments and heart problems later. He has a unique perspective as both a doctor and the parent of a cancer survivor, and knows firsthand the importance of preventing and monitoring for late effects after cancer treatment. Cancer is just something that we all have to recognize, acknowledge, cope with, live with, struggle with, rage upon, crush, and even thrive with. This show is more than knowing and fighting or beating cancer. It's more than just relaying science, hope, and technology. Together, our purpose is to demystify cancer, take away as much fear out of the diagnosis, treatment, and process as we can, defeat its grip on our lives. This is The Cancering Show. Today we have Dr. Chris Malozzi with us via Zoom. We are super excited to have you, Chris. Welcome.
Well, thank you so much for having me. It's a real pleasure. I've been following your podcast ever since it started. So hopefully I'll be able to add some insight to what I'm here doing with our patients so that others can benefit.
So as you know, we are doing all the voices of providers that surround a cancer patient, not just the oncologist this season. And we're really trying to give a complete picture to both patients and their caregivers about the entire team. So tell us a little bit more about what you do.
Well, in my particular clinic, by training, I'm a non-invasive cardiologist. And over the past 2 to 3 years, I have developed an interest in something called cardio-oncology. So cardio-oncology is really the kind of the multidisciplinary interaction between oncologists and cardiologists, taking care of these patients so that they don't have to worry too much or deal with cardiovascular issues before, during, or after cancer treatment. I've been working very closely with the folks at Mitchell Cancer Institute, you included, to see patients so that I could just provide that insight to help in whatever way I can.
And why do cancer patients need cardiology care more than maybe other medical subspecialties?
The basic answer is, and unfortunately, and I don't think this is going to change, is that cancer diagnoses and cardiovascular issues are always at the top of the list of major health problems that we face in our world. So a lot of patients have risk factors for cardiovascular disease, whether they develop it before they are diagnosed with their cancer, during, or even after. Inherently, a lot of the medications that are used in chemotherapy, radiation included, can actually cause cardiovascular problems. So it's kind of a mix between, the patient that, maybe the younger breast cancer patient who doesn't have any medical diagnoses before they unfortunately get their breast cancer diagnosis. And now they're going to be exposed to potential treatment that may cause a cardiovascular problem as a result of it. And then, you have to have this kind of team-based approach to kind of handle these problems as they come up. And I think because our two specialties are so prominent, there's this natural need for this relationship. And I think that's why this, maybe you want to call it a subspecialty. I don't know that I would call it a subspecialty, more so than maybe the recognition of the fact that we probably need to work very closely together when we take care of these patients. So that's really why I kind of turned a focus from my normal cardiology practice, which I still have, to also serving this particular patient population, because I think the patients are unique. The complications that they may encounter are unique. Some cardiologists may not have maybe the deep enough knowledge of some of those intricate side effects and things that may happen to the patient to really be able to focus on them. And cancer patients, as you know, can be rather complex at times. So it does really take a little bit of extra nurturing and extra patience and extra collaboration to get things taken care of quickly and for the betterment of the patient.
Absolutely. And as you know, we've had a ton of patients in common, including sometimes when I've actually diagnosed cardiac disease leading into cancer or a chemotherapy regimen that heretofore was unknown. I think the other thing we see, and I'm sure you know this even better than I do, women in particular with cardiac disease can have crossover symptoms with their cancer, whether that is, something that might sound like heartburn or might sound like nausea, when in fact it actually is cardiac.
Yeah, I would agree with that. I think that, lots of cardiovascular symptoms, unfortunately, are very vague at times. And we have a lot of crossover between a lot of different organ systems, and cancer diagnoses are no different. I think that that just highlights the need for the multidisciplinary approach with the patients. I also think that, in these particular incidences, sometimes these patients are going to come to you first as they're getting worked up for this possible malignancy. And that's when all of the other tests are done that are going to uncover these things. We see this a lot in, I liken it to the pre-op risk assessment for an elective non-cardiac surgery. A lot of times that's the first time a patient will come and see a cardiologist, whether they had some minor abnormality on an EKG or some symptom that someone thought maybe this needs to be evaluated before we go through surgery. And that brings forth whatever tests are indicated. And then we find out, oh, this person may actually need triple bypass surgery before their elective knee replacement. I think that's a very valid point. I think a lot of these patients will have a lot of crossover symptoms. Again, that's why I think all of us, not just cardiology and oncology, but any specialty, that open communication between providers is key, so that we can recognize these things and make sure that we can outline the best approach to treat these patients.
Yeah, absolutely. And I think we find ourselves, as you mentioned, into very different spectrums. We have that spectrum of patients that, their cancer operation may be no more than a knee replacement. The one that comes to mind for me is that obese woman with a uterine cancer related to weight that, I tell those women this diagnosis is the first diagnosis that your obesity is going to cause. Maybe you already have hypertension and diabetes, but let this be the canary in the coal mine. I can do a hysterectomy. This one's going to go away, 98% survival, but now is the time to do those modifiable risk factors so you don't die of a heart attack. And then at the other end, you can have patients with very advanced disease who their cards risk factors really cause more suffering.
I agree. I think that, again, the nature of our two specialties, cardiovascular risk factors, there are shared risk factors, like you just mentioned. Obesity can lead to various types of cancers, and obesity can lead to heart disease. There are obviously classic risk factors for heart disease that many people do develop, and many of them, again, like you said, are unrecognized going into their cancer diagnosis or their surgery, like you mentioned in that uterine cancer patient. And I agree. I think that that's going to be, a benefit to this kind of approach where you may be able to give that person that 98% cure for their uterine cancer, but then you, because of our working together and your knowledge of medicine, you're going to be able to tell them, hey, you probably need to get these other things managed pretty aggressively, because not only did we fix this, but now we've uncovered that your risk of cardiovascular disease in the future is increased. Now, I think it's even more important to highlight that sometimes, like this particular patient, for example, you're going to highlight that this obesity is one risk factor that needs to be treated. But say that was a slightly different case where they may need some chemotherapy, various chemotherapies out there that are associated with a lot of cardiotoxic side effects. That chemotherapy and or radiation, if the heart is in the field, those particular scenarios are going to set the patient up for these other cardiovascular risk factors to be more important in modifying, because it not only are they already at risk for cardiovascular disease, then you're going to compound that by adding the potential exposure to some other potentially toxic agent, such as a chemotherapy or radiation, which might accelerate that process. And I think that's where the prevention and modification of risk factors is very important. And honestly, in my clinic, I probably spend the majority of time working through the idea of prevention and modification of risk factors more so than I do spending on, potentially cardiotoxic side effects, because thankfully, not many of the patients that I see have those side effects now. There are a handful, of course, but many of them don't have those side effects yet, or they may never get them, but they do have issues that need to be recognized and treated from a cardiovascular perspective.
And that's so great to have that, again, multidisciplinary approach. How did you get into this specialty? Was there a particular experience with cancer or personal experience?
Yes, actually, this could probably take up a whole podcast in itself if you wanted to know the whole story. The saying is, when life gives you lemons, you make lemonade. So my oldest son, who is going to be 13 next week, when he was 7 years old, he was diagnosed with metastatic Ewing sarcoma. So during the process of treatment, he required multiple chemotherapeutic agents, some of them well known to be potentially cardiotoxic, along with radiation to an area of his thoracic spine, along with radiation to his bilateral chest. So, of course, with the heart lying in the field of treatment and looking at all the potential side effects of this, slew of medications that he was going to receive over the next year or so. Obviously, as his father and and a cardiologist, I started looking into the side effects of these medications. And as I worked through that process, trying to make sure when he is all done with this, what do I need to focus on as a physician father to put him in the best shape to not only survive his treatment and his cancer, but to live a healthy life after that. That's when I started to uncover the idea of cardio-oncology. I started to stumble on websites for this particular specialty. I started to stumble on research that I was looking at, and these kind of programs that are out there at some of the other cancer centers across the country. And in that whole process, it kind of opened my eyes to say, okay, not only do I have a personal invested interest in this, but as a professional, we have an outstanding cancer center. We have an academic cardiology division. There is no reason why the patients that we serve locally and beyond cannot benefit from what I have had to deal with as a parent and a cardiologist with a son who has had exposure to multiple chemotherapeutic agents and radiation that put him at significantly increased risk in the future for cardiovascular disease. And to be honest, as a cardiologist, that hurts to watch your son go through this, and he tolerated it very well. As a matter of fact, within the next few months, he's coming up on his 5-year visit. So we're looking forward to that. But I know that the fight's not over. He is at significantly increased risk based on the amount of certain chemotherapies that he got and the radiation compounding that he needs to really be focused on living a healthy lifestyle. And I need to help with that now and instill that in him, as a father, and say, you can't be one of those 20-something-year-olds that doesn't go to the doctor because you feel good. You need to keep going and follow up and manage all of these things. And when one of these risk factors, something pops up, you develop high blood pressure, you need to grab it, tackle it, treat it, do what you need to do, because this is going to increase your risk of having a late cardiovascular outcome. I pray he doesn't get.
Yeah. Wow. That's an amazing story. And as you said, such an incredible way to take that terrible experience that your family has gone through and turn it into a way to help hundreds and thousands of patients on top of that. Because, you think about your impact is not just the patients that you see, it's the fellows that you train and the patients that they see in the future.
I agree. I think there's something to sitting in a room with a patient talking about their cancer diagnosis, their upcoming treatment. And I'll be honest, many of them that I see, because of the prevalence of breast cancer specifically, and some of the medications that are used, I see quite a few breast cancer patients. And many of them, again, don't have cardiovascular issues. So imagine all of the stuff that's going on in their lives, the tests, the appointments, the anxiety, and then throw on, why in the world at 45 years old am I seeing a cardiologist? I'm getting ready for cancer treatment. Why do I have to come and do this? And I think after I talk to them and explain the importance and educate them on symptoms to monitor for, side effects that they might encounter, and then share with them that this is the reason why I do this, I inevitably, every single time, will get a patient, they will look at me, and when I say, I do this because of my son and what he dealt with and the knowledge that I've gained there, that connection is instant. They then have no problem spending
Right.
the extra minutes to kind of increase their education and awareness of what they need to be paying attention to before, during, and after their treatment.
All right. Well, I mean, don't keep us in suspense. We want the insider information. What does a patient need to do before, during, and after treatment?
So I think that falls to the patient and the provider who's seeing them from whatever aspect of oncology, whether it's surgical oncology and recognizing that they might need preoperative cardiac risk assessment prior to surgery, or the medication or the medical oncologist who might recognize that, I'm about to use some medications that might have some cardiovascular effects. That awareness then, transitions into these patients need to come. They need to know why they're seeing a cardiologist, that there is potential here, that it's not a guarantee that it's going to occur. That will get them ready to see the patient or see me ahead of time, and the patient will be prepared for that. And then they need to also be ready during treatment to identify any of the symptoms. Many patients are not going to know what cardiovascular symptoms to monitor for during treatment. So depending on what specific chemotherapies they're about to get or treatments they might receive, obviously I'm not an oncologist by training, so I frequently have to look some of these medicines up because a lot of them that you use I can't even pronounce. But I will look them up and see what kind of side effects the patients might have, and then educate them on the symptoms to monitor for, so that during treatment, it's as simple as picking up a phone and say, we need to be able to identify this, order testing if necessary, try to mitigate whatever's going on with that particular side effect, and see if any additional testing is needed in that area. And then also, make sure that if testing is needed, we do it very quickly so that we don't interrupt any potentially curative cancer therapies. I think that's the other benefit of all of this. And then I think after treatment is when probably my role becomes even equally as important, if not more, is then after that, now you are hopefully a cancer survivor. And the last thing we want to have happen is you develop cardiovascular disease more prematurely than you may have been destined to develop it anyway, and then work on modifying that and decreasing that potential risk. Because, and I've said this to many people many times, the last thing I want is for my son, for example, to go through everything he went through and then die of heart failure in his 30s. I mean, that would be an absolute shame to say I'm a survivor of metastatic Ewing sarcoma and then succumb to something that's essentially possibly preventable. So I think that that transition, just being there before, during, and after treatment is extremely important. And I tell many patients, I don't plan to be a cardiologist who's going to have you come in here every 3 months. I know you have a lot of visits and a lot of things, and you're going through treatments, and the last thing you want is to come to another doctor visit some days. But at least we're there. If a patient needs something or you recognize some issue that needs to be addressed, it can be done very quickly.
Yeah, no, and I think it is a powerful combination, as you've said, and being able to recognize things quickly and to get them managed and treated. And like you, I kind of use the, hey, we cured your cancer as the motivation for other lifestyle changes. Among them, of course, I talk about cardiac disease. They come in super tan. Then I say, I didn't, spend all that time curing your cancer so you could die of skin cancer. When's the last time you saw a dermatologist? And it's funny to me, there's a lot of ladies out there that I quote cured of cancer, end quote, because they got a hysterectomy for uterine cancer. But among those, the few times that I have diagnosed a cardiac disease and prevented a cardiac disease, to me, or a cardiac event, to me, feel like the big win. I'm like, look at this. We found your pending heart attack, and then you didn't have a heart attack. So you get to live however many more years because we found it. And that's, all because you just also happen to have a uterine cancer. And those to me are the big wins rather than the hundreds of uterine cancer ladies.
Yeah. No, I think that you bring up a good point. I mean, it's all about the recognition and taking as complete care of the patient as we can every time we see them. It's a disservice if someone, comes to me and says, oh, I'm having chest pain. And I hear the story of they've gone to, say, another physician somewhere else, or, oh, they just tell me it's anxiety. Well, yeah, but you have high blood pressure and you have diabetes and you're overweight and you don't exercise and you smoke and your mom died of a heart attack at 5. And
Right.
that it might be anxiety. And it sounds like anxiety, but I don't think I can leave it there at anxiety. I think, sometimes we have to pay attention to the red flags we're given and say, at least if we go through the steps and do what's right by the patient and go that extra mile and get the testing that's required, that's when we find things. I mean, if we just get complacent and talk about symptoms and brush them off and say, oh, well, someone else told you this was GERD or reflux disease or anxiety. Okay, well, then I'll do the same. No, that's not appropriate, I think.
Yeah.
So the fact that you're recognizing this and the goal of kind of this partnership is to get a lot of oncologists to recognize, when there's a cardiovascular symptom or issue present that definitely needs to be addressed. That's part of the other part of this relationship that I think is important, because I can pick up the phone now and talk to any of you and say, hey, if you have an issue like a patient that you sent me recently with some tachycardia, you recognize that was an issue, and then you called me up and said, I need some assistance. Let's get that patient taken care of. So I think going through all of those practices and setting up those relationships is very important.
I agree. And I think we don't talk about that often enough, the relationship between providers. You kind of opened with that, having cell phones, being able to pick up the phone and call, knowing that the other person is going to be receptive, just gives patients better care.
Yeah, absolutely.
Yeah.
And I think there's this misconception by patients that there is a universal electronic medical record that all physicians can see what everyone is thinking at all given times. That's obviously not the case. But
the universal medical record is named, it's in there, right? Just look at my chart. It's in there.
Yeah. That I think that being able to pick up the phone, and the fact that, and I alluded to it earlier, being able to pick up the phone and talk to your colleagues that are here. Again, we have a great cancer institute. I think we have a great cardiology department here, that we can have those academic discussions that are only going to better the outcome for the patient.
Yeah.
We have ideas we can bounce off of each other. We have colleagues we can bounce ideas off of. Putting yourself in a box and not reaching out to your colleagues and talking about patients is really a disservice, unfortunately. And sometimes it happens, and it happens probably all too often.
One of the other things that you mentioned were these academic discussions and things, and it comes to mind, we have so many basic science researchers at Mitchell. Are you working on this from a basic science or mechanistic standpoint?
I think the opportunities are there. I have one research study that I'm working on with a mechanical engineer on campus, looking at some initial data on MRIs on breast cancer patients who are going to receive particular cardiotoxic chemotherapeutic agents or potential toxic agents, doxorubicin and Herceptin specifically. In the world of ultrasound, cardiac ultrasound or echocardiography, there is the ability to look at something called strain imaging. And strain imaging looks at how the myocardium or the heart muscle moves with each contraction. And some of the data that has come out of multidisciplinary research in cardio-oncology is that strain imaging may be able to predict someone who is going to have potential cardiomyopathy or heart failure or reduced pump function from chemotherapy before it occurs. Now, that's one imaging modality that is available, but the same imaging can be done with MRI. So MRI, obviously the pictures are often much more clear and probably reproducible. And in this case, she's trying to gather some preliminary data to maybe move to the next step where we can do some clinical trials to look at, is this MRI study that she's doing capable of picking up this potential signal, so that we can maybe intervene before something occurs. That's just one example. Now, from a basic science type research, there's wonderful researchers at MCI and at USA. I've already had conversations with multiple researchers about the potential for these kind of collaborative research efforts. And I think a lot of cardio-oncology centers that are across the country and even the world, a lot of them do a lot of dabbling in basic and translational research, because I think that's where a lot of these things are going to be uncovered. I think there's a lot of research that's going to be needed to establish, guidelines for various things, because there are so many types of cancers. There are so many different ways to treat them and so many different medications that it's going to be very hard to slap a guideline on this particular cancer needs this particular cardiovascular workup or this sort of recipe versus, another cancer. Or cancers are not all the same. Well, you can have an early stage breast cancer and a metastatic breast cancer, and they're probably, from a cardiovascular perspective, due to the different types of treatments, may be two different animals. And I think the basic science, along with the translational and kind of the multi-specialty collaborations in research, that's where cardio-oncology is right now. I think a lot of the focus is on that particular concept, so that we can start to bring some of these ideas, give them a little more validity, a little more weight, a little more background as far as data, so that we can support some of the things that we need to do for these patients. I think a lot of that is not necessarily there, because in early, say, cardiovascular trials, sometimes cancer patients are excluded from big
Sure.
multi-center trials. So we don't know if the cancer patient is going to be or behave the same way that someone without cancer for that particular, whatever the study question is.
Yeah.
So I think there's a lot of research going on. This is a very big kind of booming area of research in cardio-oncology specifically. There's actually a graphic that I came across for a lecture that I gave, or maybe even one that I attended. If you were to look at PubMed, which is obviously one of our largest, search engines for science research and medical research, if you were to PubMed cardio-oncology, there's not many publications, and all of a sudden there's this gigantic spike where everybody's looking at various things in this field. And I think that only with time are we going to be able to kind of identify, how we can attack these various issues and do it well.
Yeah.
And with a lot of evidence-based medicine behind it.
I totally agree. One of the things that comes to mind when we think about translational research is health disparities. It's such a focus of our cancer center in our region. Some of that research speaks specifically about stress and the stress response of everything from the stress of poverty, the stress of systemic racism, et cetera. And we know, you have a heart attack, everybody says, well, just reduce your stress. So where's that Venn diagram between, cancer and stress and heart disease that says having the stress is the thing that causes both of these versus, can play into how you respond to it?
I think we all have varying degrees of stress. I know, obviously, I gave you a personal story where that year and a half, and even now, it's still not a stressful situation to think about, what we dealt with. Stress can play, obviously, many, many, many different roles in our health and the way we think and the way we do things. Cardiovascular disease, obviously, with stress, some of the easy things that come to mind. Stress can lead to hypertension, can lead to increased chance for, say, arrhythmias, or can lead to a varying degree of cardiovascular responses and or symptoms. And a lot of times, stress might be provoker to a symptom that then identifies to us that there was a problem present. And stress, whether it's stress, anxiety, there's clearly, lots of healthcare disparities in all over, not just here. And we know that, certain demographics, certain poverty levels, certain those who are maybe underserved when it comes to the availability of medical care, it's no surprise that their risk of anything, not just cardiovascular disease, but because, again, cardiovascular disease is so abundant that, it's no surprise that those things add to the increase in cardiovascular disease in those patients. And it's not just because of the stressors, it's then those stressors lead to issues, but then they don't have the access to the care that they need. There's a lot of things that play into that. I, for one, am very glad that USA has a large interest in identifying health disparities and looking into research in those areas, because I think that's very important. And we serve a very interesting population here at USA. If we don't look into that, then we're doing them a disservice, because if we can identify areas that we can improve, they're going to be better, and then our jobs are going to be easier in taking care of them.
That's so true. There's so many questions and we're getting close to our time. So I'm going to fire a couple of more rapid questions. Sure. We've talked about cardiology and traditional chemotherapy medicines and even some targeted medicines and radiation all being risk factors. What about cardiac disease and immunotherapy? I honestly don't know how those two play out.
One of the big things that's talked about at a lot of the cardio-oncology meetings, there's always 1 or 2, maybe even 3 lectures dedicated to things like immune checkpoint inhibitors. And I may be wrong, but in my perception, it almost seems as though the kind of explosion of these different therapies, immunotherapies and others, have led to this identification of that person is having a cardiovascular side effect that maybe we didn't pick up in the clinical trials that brought these medications to the market, but they still need to be handled. And I think the one that comes to mind with the immune checkpoint inhibitors is immune checkpoint inhibitor associated myocarditis. That is talked about at every meeting that I've attended. There's databases and patient registries being formed to kind of look at this. You know, these immune checkpoint inhibitors are pretty potent medications. I mean, you're using the immune system to battle cancer, and that can then lead to other sequelae. And in this case, you get this fulminant inflammatory process that involves the heart. And some of these patients have this rapid development of myocarditis and heart failure, and some of them don't survive. And I think that when we started seeing case reports of things like this, I think that was one of the stokes to the fire that said, hey, we really need to look at these potential cardiac side effects of these medications. You know, all the different therapies, like I said, every one that you guys are using, I often have to go into the literature before, during, or after when I see a patient and look up what kind of medication that is, look at the different side effect profiles from, you know, the package insert from the drugs and when they, in the research that brought them to market, to see what do I need to potentially be worried about in this particular patient.
From our perspective, you know, we never want somebody to hear our podcast and say, well, I'm never taking those drugs. I seem to still be hearing from you that those side effects are rare and that in most patients manageable with appropriate therapy and when caught early.
Yes, I would agree with that. I think, and I'll use my son's case as an example, and many of your patients probably feel the same way. If they actually sit down and look at all of the side effects of all of the chemotherapeutic agents they might receive, I wouldn't be surprised if many of them go, are you kidding me? Right. I mean, the laundry list of some of these medicines, and I can vividly remember the day that my wife and I are sitting there at the table signing off on all of these medications that our son was going to receive, looking at all of, not just cardiovascular, but all the side effects. But I mean, in some cases, especially like my son, the trade-off is not a good answer. I mean, if we don't do this, then this is what's going to take him from us.
Yeah.
So I think in most cases, what I tell patients is, you are here to see me because some or all of your chemotherapy or your radiation has the potential to do X, Y, or Z. And then I explain to them that these are the things you need to monitor for. And these are the things that if you find them and we intervene early, then we could potentially correct. But also to make sure that they know that, yes, these are rare. I would never tell your oncologist not to do this particular therapy because they know best what's best for you. I don't have oncology training. I'm not going to tell you that you need to change your chemotherapy because of a potential cardiovascular risk, but I'm here in your corner if you develop one so that we can get it handled appropriately and quickly in the case of being in the midst of chemotherapy, that the chemotherapy can keep going and there's no interruptions and they can get the outcome that they desire from their cancer treatment.
I couldn't think of a better place to stop us. There's still so much to this conversation, but I really want to thank you for your time today and your expertise. We are so grateful, and I'm certain patients will benefit from hearing this.
Well, I really appreciate you giving me the time to come and kind of educate patients on what we're able to do for them from a multidisciplinary aspect. And I really have cherished the ability to work with these patients alongside you guys. I really think you guys are doing wonderful things. And the fact that these patients are surviving longer so that they can develop heart disease is only kudos to you and researchers out there that are just advancing cancer therapy like crazy. So well done on your side. And again, thank you guys for having me.
Thank you so much.
Thanks, everyone, for listening to The Cancering Show with JYP, Dr. Jennifer Young-Pierce. Please subscribe, rate, and review this show on iTunes and anywhere else you listen to your favorite podcasts. Want us to deliver the Cancering Show to your email inbox? Contact us at cancering.com and we can make sure you never miss an episode. We would love to know what you think about the show, or if you have any suggestions on topics you would like to hear. You can reach out to us on Facebook, Twitter, and cancering.com. Till next time, be healthy, happy, and always thriving.
This show is brought to you by the University of South Alabama Mitchell Cancer Institute. MCI is a cutting-edge cancer research and patient center built to fight cancer smarter in Mobile and Baldwin County, Alabama. Our researchers and clinicians focus daily on the struggle against cancer, serving a potential catchment population of more than 4.1 million people, with a singular focus of advancing cancer diagnosis, treatment, and prevention throughout the Gulf Coast and beyond, with science, technology, and hope. Want to know more about the Mitchell Cancer Institute? Visit us at usamci.com or search for us on Facebook, Twitter, and Instagram. Mitchell Cancer Institute is a member of USA Health. To learn more about all of our hospitals, clinics, and services, visit usahealthsystem.com.